Hello, and welcome to the National Coalition on Healthcare live virtual conference, The Path Forward, the 2020 Elections, and Reimagining the Healthcare System Amid Crisis. Thank you for joining us. My name is Michael Boudros. I'm the Policy Director for the Coalition, and I will be the host throughout the event. I have a few housekeeping items before we begin. First, to keep the conference on time, we will not be accepting live questions. However, you are welcome to submit questions and comments afterward to us at contactus@nchc.org. Second, the conference will be recorded and a link to the recording will be sent to registrants after the event. Finally, a big thank you in advance to all of our speakers, moderators, and media partners for their participation today. I will now introduce John Rother, the president of the coalition, to give some opening remarks and introduce our moderator for the first panel. John?
Thank you, Michael, and welcome everyone. We are delighted to host an important discussion, not a debate, but a discussion about the path forward. We know that this is a critical time for healthcare, and the coalition is, I think, well positioned to host this event. We are made up of about 80 different organizations, doctors, hospitals, health plans, consumer groups, and we are nonpartisan, but very much focused on the issues of healthcare affordability, quality, and access. I'm very pleased also to say that we have a partnership with the Healthsperian firm, which is supporting us and have been very successful. We also want to say that we are very pleased that Noam is our moderator today, a longtime friend, an outstanding health reporter, and a person who's done some really groundbreaking reporting on the various dimensions of the healthcare crises that we face. So Noam, welcome, and I turn it to you now.
Thank you. Thank you very much, John. It's a pleasure to be with you as well, and to once again be working with the National Coalition. I am, as John mentioned, going to be the moderator today, and hopefully I'll have a bit more success than Mr. Wallace did the other night. I'm counting on our three panelists to be a little bit better behaved, and we'll hopefully have a productive discussion today about an issue that I know many of you care very deeply about, and that we as a country have an enormous amount invested in. So just to run down the organization of our discussion, I'm going to introduce our three excellent panelists in a moment, and then I'll try to guide our conversation through the major healthcare issues facing the country right now. We really are lucky in who we have here, and let me start by introducing our three panelists. First is Congressman Greg Murphy, a Republican of North Carolina. Congressman Greg Murphy is a urologist and a politician who's a member of the U.S. House of Representatives, representing the 3rd Congressional District, which he began representing in 2019. He formerly served as a Republican representative in the North Carolina General Assembly from 2015 to 2019, and he is representing the Trump campaign as a surrogate for this discussion. We're also joined by someone I know many of you know very well, Chris Jennings, the president and founder of Jennings Policy Strategies. Chris Jennings has over 3 decades of experience in health policy at the White House, Congress, and the private sector. He is, as I mentioned, the president and founder of Jennings Policy Strategies, a nationally respected healthcare consulting firm committed to assisting foundations, purchasers, health systems, and other stakeholders develop policies to ensure higher quality, more affordable, and sustainable healthcare. And Chris has been working, I know, to advise the Biden campaign. Finally, we're joined by Rodney Whitlock, Vice President of McDermott+Consulting. Rodney is an accomplished healthcare executive with more than 2 decades of experience on the Hill, where he specialized in rural health, the healthcare safety net, and disability policy. Rodney has also been an adjunct faculty member at George Washington University for 20 years. So let me get our conversation started maybe by asking first Congressman Murphy and then Chris to talk a little bit about the way that the two candidates are and campaigns are thinking about some of the major healthcare policy challenges facing the country. And I want to start, we'll break this up into separate segments if it's okay with all of you. And let's start by talking first about the pandemic. I don't think anybody disagrees that this is the healthcare crisis of the moment. More than 200,000 Americans, as many of you know, have died. The US has suffered a disproportionate amount of suffering as a result of this crisis, particularly compared to other wealthy nations around the country. Congressman Murphy, let me start with you. Can you talk to us a little bit about what a second Trump term might mean for how the United States approaches this public health crisis? And are we going to get more of the same? Are things going to be better? Walk us through what President Trump would do for us in a second term.
Great. Thank you, Noam, and thank you guys for having me. I appreciate the opportunity just to speak and have a discussion. This is nothing that, in my opinion, there is a perfect rule as far as healthcare. I've been taking care of patients and still take care of patients for 30 years and have worked at every level of healthcare that there is in the trenches. So I think I bring a unique perspective, not just from reading papers and working in an office about healthcare, but from actually seeing patients and talking with them. If you look at this pandemic, obviously this is something that the world has never encountered before, at least in modern times. We dealt with H1N1, we dealt with Zika, we dealt with Ebola, each in their own different spheres. But in January, this obviously came out that China had a virus they were trying to contain within their own country, but were not being very open to the rest of the world. And the president did what I believe was really a pinnacle moment in that he shut down flights from China from coming out of their country. If he had not, I truly believe, New York, Boston, Philadelphia would have looked like Italy, where literally everything was being overrun. So I think that's an insightful action he did at the request of Dr. Fauci. At that point in time, that made a massive difference. I will take issue with you that we have taken a disproportionate amount in the United States. I do believe there is a vast amount of underreporting coming from countries like China, Russia, especially North Korea, where there are no cases, in the rest of the world. While we obviously have suffered in the United States, we've done actually a pretty damn good job of getting hold on things. You know, our case fatality rates are less than a good portion of Western Europe. So, you know, we were trying to build a plane while flying this. And unfortunately, you know, as I said, I put out 30 videos on this topic. Unfortunately, and I said this earlier, that I feared that this crisis would be weaponized for political purposes, and unfortunately it has. I mean, from hydroxychloroquine to the use of masks to now even the vaccines. So what does the future look like? On May 25th, I believe, May 15th, we started Operation Warp Speed, which was an unprecedented, actually Manhattan type project to develop a safe and effective vaccine in the United States. And the president knocked down barriers, which I've been fighting with in medicine for 30 years, regulations because of overgrowth of government, burdensome government, to knock down, to make a pathway that we would have a safe and effective vaccine in record time. And that's just what we're doing. We now have 8 vaccines in final phase 3 trials, one of which may actually come out as a compassionate release this month, because it's shown such a disproportionate salutary effect in phase 3 trials. And so what the future of the pandemic looks like is for a vaccine. But now, unfortunately, you know, in a good year, we have 60% of America take the flu vaccine. And, you know, that's when it's 70% effective. A good vaccine, if we're lucky, is 70% effective. And some results from Moderna and some of the other companies have shown that they've had in vivo studies, results of greater than 70%, which is very encouraging. But unfortunately, it's become weaponized, where we don't trust all of a sudden, just because people don't like the personality of Trump, they're all of a sudden now not trusting the medical and scientific community. And I take that personally as an affront, because my colleagues in medicine, I believe, are not political in trying to make sure that we develop something that's safe for our patients. And that's what's tragic. So I think 20% of folks take the initial vaccine. I'll be one. I'll sign up for it first thing. I already have. And I'll do what Jonas Salk did. I'll have my family take it because I believe in the process. I believe what we are doing understands and takes scientific rigor to go to move forward. So I think that's the future of what this country needs. We can debate other topics, but again, when the academics look back on things in the next quarter century, we'll say, hey, you did this right. Hey, you didn't do this quite as right. And of course, there's time for that. But in the moment, I think the decisions made were the best ones possible and the ones best moving forward for our nation.
Thank you, Congressman. And I'm going to turn to Chris for a second. I do want to correct the record a little bit, though, Congressman. You mentioned our case fatality rate. It is true that there are a couple of countries in Western Europe with higher case fatality ratios, but ours is about 62 per 100,000, as you probably know, according to Johns Hopkins. The Netherlands is 37, France is 47, Canada is 25, Finland 6, South Korea less than 1 per 100,000.
Sure, I said some. I did not say all.
But most wealthy countries actually have considerably lower fatality rates in the United States. Chris, you want to talk a little bit about what would President Biden look like in terms of approaching this virus and doing things presumably differently?
Well, sure. And Noam, thanks for having me. And Dr. Murphy, I want to thank you for being here today, and also for the services you provide ongoing with your patients today, but also what you've done internationally in moments of crisis, both internationally and domestically, as a matter of fact. So don't think that goes without notice or appreciation.
Appreciate that. That's very kind.
I believe that that it is important that we try to make that we address the current calamity, the crisis of the pandemic, as apolitically as possible. And absolutely, we should all hope and pray for a safe and effective vaccine. But I guess where I do take issue with Dr. Murphy is I think that there are really very legitimate and bipartisan people from all sides of the spectrum who would not agree that the president has led well in this COVID-19 dynamic in virtually any respect. I do think the closing of the border did have a positive effect, and the president should be praised for that, taking a quick action. But the idea that the rest of the handling of COVID-19, both in terms of how he has handled deference to science, shown leadership about appropriate use of social distancing and use of masks, slow reaction to utilizing all aspects of the federal government, including the Defense Production Act, to accelerate and intervene substantially on a quick distribution allocation and appropriate allocation of PPE and testing, has been called into serious question by people of all sides of the science debate, of all sides of the regulatory, and all sides of the independent expert community. And I do believe that, and I know the Vice President does, with unfortunately tragic results. We've had a situation where states were literally competing against one another for accessing both PPE and testing. And this was a time when, frankly, as I've seen President Bush do this in previous times, as well as Democratic presidents, in moments of a national crisis, that we come together behind our president and we don't point fingers. We don't say certain states are better than other states. We work collaboratively to address these issues. And so, obviously, I don't believe that is a political statement. I think it is a statement of fact. I think we do need to have new leadership, and we need to have at its core a deference to science, a deference and empowerment of scientists, And also, but not blind. You get the information, make informed choices, and contemplate the best interventions that will address both our health and economics. From the very beginning, the Vice President has said that if we're going to address the economic challenges facing this country, we have to take care of COVID-19. He said that repeatedly, and he's absolutely correct. I think that had we intervened more effectively earlier, we might well be in a much better position now. But it's sort of water under the bridge. We need to move ahead, and we need to get new leadership. And I think with the Vice President, you will see that he will utilize the full powers of the federal government. He will be deferential to the regulatory agencies. He will be moving very, very quickly to have a thoughtful both approval process of a vaccine and an equitable and efficient distribution of that vaccine when it becomes available, and also to rationalize how we do testing, because really in the interim, we really must do a much better job on that front, and he has a plan to do that. So I'll stop with that, and with respect to Dr. Murphy, probably disagree on the perception of the president's handling on this issue.
Thanks for that, Chris. Let me bring in Rodney here. Congress has also attempted during this crisis to help provide aid to Americans and businesses and others. Can you talk a little bit about what the implications of the election may be for how Congress can help shape a response to the crisis, and what that may look like depending on the outcomes next month?
Sure, and thank you all for having me. And I have the relatively simple task of not representing either side, but simply representing an inanimate object called the process. And my experience working on the Hill for as long as I did, and talking about it from that perspective. And so no matter who wins the election, they're going to have to deal with legislation. And as Congressman Murphy knows, as Chris knows from working in administrations and on the Hill, the process is waiting, and the process is certainly going to present its challenges. That the House of Representatives, where the majority can move pretty much anything it wants at any given time if they're willing to stick together, can certainly accomplish what they want. We'll probably watch that this afternoon in the House. The Senate, though, continues to be a very different beast. As long as there's the existence of nattering little concepts like filibusters and reconciliation, process is much more difficult. The administration, of course, has great tools it's at its advantage to put to use at any time, but those are also subject to challenge. As we've seen with this administration across numerous policy areas, that when they want to take unilateral action, those can be subject to challenge in the courts. And that's why the process is going to require at least some level of consensus as currently structured to accomplish what either side wants post-election.
And before we move back to Congressman Murphy and to Chris, Rodney, what do you think the prospects are that that there can be some consensus about additional federal intervention? I mean, I think many people would have thought at this point that there would be an additional assistance package that would have gotten through Congress. Who knows? Maybe we're heading in that direction, but it's taken a long time, and certainly many feel that the policymaking process is, if not fully broken on the Hill, it's pretty close to it, particularly when it comes to healthcare. Do you see any chance that dynamic changes?
So I'll be. This probably will come across as controversial to both my colleagues here. I think both of them are completely right in where they stand. That for the Republicans, they've said this is what we think is the next appropriate action to try to provide both assistance for the public health and economic crisis. The Democrats, they are perfectly correct in what they are saying in terms of what they think is the response. And if there's not enough consensus for agreement somewhere betwixt and between the two, then the only option is for an election. And we'll have one of those shortly to determine what Americans think is the right direction. And hopefully they will send a signal that does not say, well, we think you're both sort of right, go work it out. If they do send that signal, hopefully the policymakers will hear that and behave accordingly.
I want to caution you, Rodney, no more of those rosy kind of assessments. Okay.
Oh, I can do glass half full of battery acid as
Okay.
necessary.
All right. So let's turn a little bit to health policy here beyond COVID. And Congressman, I know I keep coming back to you and sticking you first here, but let's talk a little bit about specifically health insurance and health insurance reform. The president himself is talking a lot recently about protecting Americans with pre-existing conditions. That obviously was a major goal of the Affordable Care Act 10 years ago. He's been very critical of that and has advocated alternative approaches. Talk to us a little bit about how could President Trump actually protect Americans with pre-existing conditions, especially assuming that the Affordable Care Act is invalidated by the Supreme Court.
Sure. Let me be first and very transparent in saying this, and I've said this all along. I believe there are certain facets of the Affordable Care Act that were beneficial to the American public. I believe protecting pre-existing conditions was one of them. Keeping kids who are up to 26 on their parents' health insurance was another one. And so, this was not an all or none thing for me. And I don't think it is for most people personally. But if you look at what the best way to get health insurance for the people of our nation, it's called a job. It's called a job. And this is where, when the economy was going at the greatest steam that it was back in February, the greatest steam in 50 years, when the unemployment rate was in record lows, people had health covered employee insurance. Now, of course, I've been in healthcare for 30 years, and I've taken care of plenty of my share, and if not much more than my share, of folks that did not have insurance or were underinsured of those type of disorders. So I will tell you, I took an oath to take care of people regardless of their ability to pay, and I stand by that oath, and I believe it's an important thing for us to do. Now, we have to get down, and I think there's some possible differences of opinion between what healthcare is. Is it a right? Or is it a societal obligation? And I believe there is a difference in that. But if you look at what health insurance is going to do for what we do for our American public is, number one is we get them a job. Employee health care insurance covers the predominant number of individuals in the country. Then you also have associated health plans, which helps those smaller businesses which cannot gather insurance by themselves. They can do it collectively with other businesses very similar to them. And then between folks who are between jobs, being able to get short-term health care insurance, which is a lot less expensive than doing on COBRA plans. And then, of course, there are part of our society, which appropriately so we take care of through Medicaid and some parts through Medicare, that help those less disadvantaged, help those that are not able to work. But it goes back to the facet of big government versus smaller government, with letting the marketplace and private practice rule the day. Control the day. I personally have been in healthcare, and I've seen how big government ruins healthcare, how it got between me and my patient, how it ruined medical practices, how it blew up the amount of administrative burden, how it blew up costs. And one thing the Obamacare truly did was look at our premiums between 2013 and 2017. In a lot of places they actually doubled. They did not decrease like the promises were. And so again, this is where the marketplace pulls into effect. And I'll be happy to talk about other things that we go through, but I don't want to monopolize here.
Let me
where the insurance plan goes forward.
Before I turn to Chris, thank you for that. Let me make sure I'm understanding what you're saying. So, to protect Americans with pre-existing medical conditions, President Trump would either get people a job or allow them to get association health plans or short-term health insurance?
Well, no, those don't in and of themselves guarantee pre-existing conditions, but there have been several attempts by the Republican minority in the House to put forth legislation that would, absence if the ACA was repealed, aside from that, would guarantee that pre-existing conditions would be perfected. But unfortunately, Speaker Pelosi does not want that win for the American people, does not want that win for
So just to be clear, then the second Trump administration would require by law that health insurers cover Americans with pre-existing conditions?
Yes, that is correct.
Including short-term plans?
I believe it's going. I'm not going to dance on that one a bit, but Everybody who has a pre-existing condition will be covered. That is the intent.
I see. Okay, Chris, do you want to talk a little bit about what would a Biden administration do to protect Americans with pre-existing medical conditions beyond the Affordable Care Act? As Congressman Murphy noted, and others have as well, the Affordable Care Act did bar health insurers from discriminating against Americans with pre-existing conditions. But affordability has been a major challenge for a lot of people, and if you can't afford coverage, obviously you're not protected.
Right. Well, let's first start with where the Republican Party is, which is, and particularly President Trump, is a week after this election will be arguing in front of the Supreme Court to completely invalidate the Affordable Care Act and pre-existing condition exclusion protections that exist, and working for years to try to repeal the legislation without any type of viable policy alternative. And even when you look at the alternatives Republicans are talking about, they do have big holes for people who don't have pre-existing condition exclusions through the short-term plans. That does not provide pre-existing condition exclusion protections in any way, shape, or form. It does not provide any explicit protections for all those states who have not expanded Medicaid. So they don't have anything, they can't afford anything. They're just without hope of having any coverage whatsoever. And even those, when they say that they're advocating pre-existing condition exclusion protections for other people, they're allowing for significant cost increases for people who are older, for women, and for other populations. And so, if you to your point, Noam, if you can't afford the healthcare in the first place, it doesn't matter whether you have the protections or not. Now, you're right to say that there does need to be more focus on affordability, and that is precisely what Vice President Biden is proposing through a series of more competition and choice, through a public option, through a much greater focus on finally actually moving beyond talking about prescription drug cost containment, but actually acting on it, through a host of significant new increases in tax credits for populations across the board, and for covering all those other states who haven't expanded Medicaid in the first place. So he has a whole host of policies. It would substantially increase coverage, it would substantially reduce costs, and it would not only reduce premiums, but it would also reduce cost-sharing burdens that have burdened folks. Lastly, I just want to say, when people are saying, I'm going to rely on the employer-based system in all cases, we've just seen through COVID-19 that people can't rely on only their employer-based coverage to provide coverage when they're most in need. It's been tragic. And we've also seen that over the last 10, 15 years, how employers who have been really burdened by healthcare costs, because they're paying about 2.5 times what the Medicare program is paying for healthcare, they address that by keeping their premiums a little bit more moderate or affordable by just shifting costs through higher and higher deductibles. And so people show up in the doctor's offices with very extremely high copays that they can't afford in the first place. We need to address all of these things, and the Vice President does just that through his proposals.
Rodney, I'm going to bring you in a second, but if you go to the Biden campaign website, there actually is quite a long list of things that presumably President Biden would do. You mentioned to Chris a couple of them. Congressman, I go to the Trump website, fairly regularly to see if there's any update. I can't find a healthcare plan. Have you seen a plan from the White House for what actually would happen if the Affordable Care Act is thrown out?
Yeah. No, I will tell you, no, man, just to Chris's point, we have a broken healthcare system. There's no doubt that the healthcare system is broken. I've worked across the world and I've seen how other healthcare systems work. Thinking that the government option is an alternative, adding another VA, adding another complicated mess like Medicare that I've worked with for 30 years to think that that actually will drive down costs is about as, in my opinion, as truthful as saying that the ACA would lower your premiums. It's not going to happen. It's not going to happen until we attack the root cause of things. And the president has put out executive orders to lower the cost of prescription drug prices. And actually, for the first time in 30 years, they've actually decreased this past year. There are several other initiatives that we're working on. We're working on surprise billing. And actually, last week, the president was going to come out with an executive order on surprise billing. And I, and with other members of the Doctors Caucus, put a little pause on that because it needed some more needling. There are several different initiatives, the biggest of which, not the biggest of which, one of which will be surprise billing, where patients come in the emergency room if they're not covered by an insurance, that they get whopping bills. That needs to be fixed, pulling the patient out of the equation. That needs to be done. Working on prescription drug prices. And I will tell you, this is one thing that I don't believe is in any of the president's literature, but it's one thing that's one of my pet peeves, and one of the things that I'll be working with the administration on, are two things actually with drug pricing. One is direct-to-consumer advertising. And I think we need to attack that. We're only one of 2 countries in the world.
Congressman, can I just interrupt you? I'm so sorry. I want to get to prescription drugs in a little bit.
All right.
But before we move off on there, I don't think you answered my question. Where is the president's plan?
Well, I haven't looked on the website, so I can't tell you. I've worked it through briefings and everything else like that. I'll be happy.
So has the White House presented you with a plan? Have you seen a plan?
I have one from my Republican Study Committee that we work with the White House on, yes.
So there is a legislative plan ready to go if the Affordable Care Act is invalidated that would assure that Americans with pre-existing medical conditions could get access to health insurance, that they wouldn't have to pay more if they have a pre-existing medical condition.
Yeah, again, that's already been attempted legislatively and blocked by Speaker Pelosi.
Okay.
So yes, the answer to that is yes.
I haven't seen anything from the White House. That's why
Okay. Well, I mean, we have one from our Republican Study Committee that has been done in concert with the White House, so I'd have to research that separately.
Okay, Rodney, let me bring you in here again. You're the unaffiliated observer here. We've been stuck, I think, as this little interchange maybe illustrates, in something of an impasse politically on healthcare and health insurance reform, specifically since the ACA. When you look forward, do you see any prospect for the parties working together, either with after the election, with the Trump second term, with President Biden? We may have to if the Supreme Court in fact throws out the Affordable Care Act. What are the prospects that the parties could actually work constructively on this?
It's a challenge. It's a challenge because the fundamentals are very separated. One of the things, though, that I think for those of us who work in the space can say, listen, I'm an extraordinarily big fan of a quote from Thomas Sowell. There are no solutions, only trade-offs. And that I think that if you really look at healthcare, that's absolutely true. That my 2 colleagues here, they are presenting as solutions what are effectively an organization of trade-offs that you make. The challenge we continue to face is the inability on a bipartisan basis to get an agreement on the legitimacy of the trade-offs made. That you lack in, for example, the last major active action in healthcare prior to the ACA was the creation of the Part D benefit. There was enough of a bipartisan consensus there, not saying it was complete, but there was enough of a bipartisan consensus there that the trade-offs made in the creation of that benefit were legitimate and have continued to exist now for the better part of the last 14 years, with an expectation of how it would work and that its structure was legitimate. What we need to find our way to is a place where we start to look at the trade-offs we make on a bipartisan basis as legitimate. Does California versus Texas present us with that opportunity? I think, and I'll take criticism for this, I think the rhetoric around California versus Texas is extraordinarily hyperbolic. I just watched a very august research institution today put out a piece where they said, the repeal of the ACA would lead to the end of the Medicaid expansion. It's not true if the Supreme Court focuses on Title I only. Yeah. The way to think about California versus Texas is as a set of light switches. Every section in the ACA is a light switch. The Supreme Court has to make decisions on which ones they're turning off and which ones they're leaving on. And then Congress and a next administration, if the Supreme Court decides to turn any off, which ones they want to return to. Menu labeling, biosimilars, the Medicaid expansion, or pre-existing conditions. But whichever way they go, the Supreme Court, inclusive of not doing anything, hopefully somewhere that will lead to an opportunity to reach some level of bipartisan consensus.
So I'm glad you framed things that way, Rodney, because I think anyone who's been around healthcare for a little while, I think would agree that any policy effort in this space requires trade-offs, and the Affordable Care Act was in fact something of an exercise in trade-offs. Chris, when you talk about what Vice President Biden is talking about, his plan does in fact look to expand government intervention further into healthcare. By, among other things, creating a public option, an additional public insurance plan to reach people who are not being covered, particularly in states that have not elected to expand Medicaid. There are trade-offs involved with that, and Congressman Murphy raised some of them. Anybody who's been in a doctor's office can attest to the fact that the government's involvement in healthcare does tend to increase the burden, the administrative burden on practices. Talk a little bit about how Vice President Biden's campaign thinks about that and why we shouldn't be concerned that just further government intervention may just pile on a system that we don't think is working particularly well right now.
Well, there's so much to talk about right now. A couple things. One is there's no physician that I'm aware of that loves what private insurers do in terms of prior authorization restrictions and quality rules and different reporting data. My son's studying to be a physician. We have plenty. We have so many physician advisors in the Biden health team. I can't even tell you, on and on and on. And they couldn't be more frustrated with the private insurance industry. So let's not suggest nirvana exists in the private insurance world. Secondly, in that world, there's not a lot of satisfaction with affordability. And there is a desire for greater affordability, which can be done through multitudes of policy interventions, including greater focus on drug cost containment, which the President Trump has talked about for 4 years and has never delivered on anything. He's talked about surprise medical billing. We still haven't enacted anything. There's bipartisan, bicameral support allegedly for that policy, but it's the very providers who really say they want to do something are blocking policies in that area to get it done. So I would just say that it's time that we had a little bit more competition and choice to provide new options for people who can't afford their health care. And there's no doubt in my mind, I would take, if you ask most physicians and how they interact with Medicare versus the private insurance industry, they would say Medicare is easier. They reimburse quicker. They're administratively are less burdensome than many private insurers. So I don't get into this public-private thing because look, Medicare, Republicans' greatest, in their view, achievement, it was the Medicare Advantage program, which is part of the Medicare program, And when we talk about Part D, when we just hear Rodney talk about Part D and the bipartisanship, I'm glad he raised that because it was not as really more Republicans, but it was bipartisan. And even more importantly, after it was enacted, even after Democrats who opposed it, they worked very collaboratively with Republicans to improve Part D over time, as opposed to spend all their time trying to repeal it. That to me is what we should be seeing in this country, not this polarized debate all the time about this, because it was theirs, we're not going to work to improve it. That to me really seeds all the problems of cynicism and skepticism that the public understandably has with our political process. And I think it's extremely sad. And lastly, I'm going to just end with a bipartisan suggestion to the Congressman. He just mentioned that he really wants to focus on direct-to-consumer advertising and what we allow in this country and how it drives healthcare costs. And I could not agree more with him. And he may want to look at Vice President Biden's proposals that would explicitly eliminate the tax subsidy that we have in this country for advertising these products. And I think that could be the first thing that Dr. Murphy and a new president-elect Vice President Biden could get done. And I hope that they do. So I'll end with that note of bipartisanship for you.
Once again, I have to caution you all to stop it with the Congressman. I want to get to, I know everyone's chomping at the bit to get to drugs. We'll get to drugs in a second. But I want to just throw it back to you for a quick question, because I think the point.
Well, do I get a chance to rebut not rebut, but comment on what Chris said?
Yes. That's I want to come back to you in part to respond, but I want to focus it a little bit if I can. And that is to ask. Chris raises a point about the Affordable Care Act, which I think is interesting, because I've been covering the Hill for 15 years actually. Washington for 15 years. Started on the Hill. And watching the Republican response over the last 10 years and the rhetoric, frankly, that President Trump has used around the Affordable Care Act doesn't sound anything like the note that you sounded at the beginning, that you actually think protections for pre-existing conditions are something we all ought to agree on. In fact, there's been sort of very hyperbolic rhetoric about the law and it's the second coming of Lenin and so forth, and numerous efforts not to refine it, but to throw the whole thing out. So is there an opportunity, can Republicans, frankly, approach the discussion about the law and in changing it in a way that doesn't involve this sort of nullification kind of rhetoric and policy that we frankly do hear from the White House pretty regularly?
Well, as Chris said, this should be a bipartisan issue, and I applaud him for that. I'll go back to what Rodney also said. When it happens with the ACA, it's going to be a cafeteria approach a little bit. Is what they deem as constitutional, what they do not deem as constitutional. The problem is, and this is politics, where it's so partisan, where one party or the other, there's plenty of guilt to spread around here, will attack the other merely because they're initiatives. I mean, you saw that, we said in the House when we tried Republican initiatives to put forth, protecting pre-existing conditions, et cetera. And the same with the ACA. And, as Speaker Pelosi said, we don't worry about what's reading in it, you'll read it after we pass it. It was that kind of verve with a belief thing that put a bad note on folks. Yes, there is plenty, in my opinion, to work on bipartisan efforts to move things forward, regardless of the administration. And I will say to Chris, with the direct-to-consumer advertising, I have brought up just that point about legislation of working to eliminate any type of avenues for direct-to-consumer advertising, and the tax thing is one of them. I've worked to that and kind of gotten blocked in that regard. So I look forward to doing that in my next session. But I think to answer your question, is there an avenue for bipartisan support to move forward? I believe there is. There's always rhetoric coming from one party to the other. Regardless. And when the rhetoric settles down and the dust moves on, that's when the real work begins, to sitting down at a table and saying, hey, okay, let's live with this. I can live with this. And let's do what's right for the American people as a nation rather as parties.
All right, let's talk about drugs. So there appears to be at least some agreement between the two of you that we should approach direct-to-consumer advertising differently. Congressman Murphy, President Trump has expressed interest over the last few years in tackling prescription drug prices. It's also correct, as Chris noted, that a number of the proposals that he has talked about have never advanced beyond the proposed regulatory phase, whether it be drug importation, his latest proposal to index the price of Part B drugs to what other countries pay for them. Is the Trump administration prepared to actually move forward with legislation to do some of these things? We're sort of 3.5+ years into this administration. We're just getting executive orders now, 2 months before the election. I think people could be forgiven for thinking, where was this 2 or 3 years ago?
Good point, valid point. However, the congressional, the office of the legislative branch is one that's supposed to bring forth legislation. And if Speaker Pelosi won't allow us in the minority to bring forth legislation, it's dead on arrival. So things have to come from the Senate and they'll get blocked by the House. This is where, blaming the president for not having something on surprise billing is a little bit disingenuous, because this is something that comes from the House and comes from the Senate. There are 4 different bills that we've been working on, and I think we finally have come to a good point with one of the Senate bills to try to just have the level playing field between insurance companies and providers. Chris said that he thought the providers were getting in the way. We just wanted a level playing field. Some of the legislation actually for surprise billing gave that all to the insurance companies. But as you move to your point, it's to the point where the president's gotten sick, tired, and fed up with the legislative branch. And that's where these executive orders are come in. Some of that, in my opinion, is warranted. Some of it's not warranted.
With respect, I just want to remind the Congressman that you had the Congress in 17 and 18, and nothing happened.
Well, with respect, Chris, I wasn't here.
Well,
all right, everybody's blameless. So let's actually talk.
We had to do something nasty. Come on.
Let's talk about a little bit of some of the specifics that are on the table. We talked about direct-to-consumer advertising. One of the things, Chris, that Vice President Biden has proposed is allowing Medicare to actually negotiate prices on behalf of Medicare Part beneficiaries. It's something that President Trump once was in favor of. Why would that, Chris, be advantageous, and what would it mean if there was a President Biden?
Well, first of all, you're right. President Trump has said he supported that throughout the election of 2016 and signaled throughout the following 2 years he wanted to work on something. And then he sent a statement of administration policy, so-called SAP, to veto the underlying House bill. And so, look, I'm going to set President Trump's record on drug costs aside, because it's been a dismal failure by the walk has not matched the talk. There's plenty of evidence on that. I'm more than happy to go chapter and verse, and I know you don't want me to do that, but if you want me to, I absolutely will.
No, talk about what President Biden would do.
All right, fine. So with a President Biden, he believes that we do need to. He thinks it's outrageous that Medicare is explicitly prohibited to move ahead, but that secretary will need to have explicit enforcement mechanism to do that. Remember, if you look at drug costs in this country, in the middle of a COVID-19 crisis, we're seeing record profits from the pharmaceutical industry. And while there have been some drugs in aggregate across the board, if you look at brand drugs that face little or no competition, we're seeing extraordinary price increases well above inflation at a time where people are losing their jobs. I mean, this is outrageous, just straight up outrageous. And he sees that. And if you ever run for office, and if you go to talk to real people, Republicans, independents, Democrats, they will say drug costs is the #1 issue and out-of-pocket cost burden for themselves. And they want to see members of Congress and a president to actually do something. And so, yes, he has a very specific set of policies. He does everything from empowering the secretary. He has an independent board to evaluate drug costs and do it in such a way where we're finally addressing the issues of drugs facing little or no competition. He's very, very supportive of the general direction that the House has taken by providing real enforcement mechanisms to empower the secretary to negotiate those prices. And he thinks that those types of prices should be moderated, because the idea that Americans are paying a drug prices that far exceed what their industrial competitors are paying is just absolutely unacceptable. And lastly, we shouldn't be seeing inflation in drug prices, particularly in the brand area, at a point when people aren't even getting wage increases at this level. So he has an explicit enforcement mechanism very similar to what a bipartisan bill in the Senate that's gone nowhere in Senator McConnell's Senate, which is the Grassley-Wyden bill. So he's very, very open to all those. Yes, he has the DTC policy. He has a whole host of other initiatives. I'd be happy to go through if you want to.
So Congressman Murphy, talk a little bit that there are a long list of things that Vice President Biden is talking about. President Trump has, as you noted, a couple of executive orders on some specific policy. Is that the sum total of the Trump prescription drug plan?
Well, I think as we move forward, again, this is something that, and I will agree with Chris, you know, my patients, whenever I see them, I get calls back all the time. I can't afford this medication. Is there a cheaper alternative? So I think there's uniformity in the disgust, actually, of the American public of drug costs. But we also have to look a little bit further than just what pharmaceutical profits are showing. We have to look at how much it takes to bring a drug to market. We have to look at see who are the ones that manufacture these drugs. But we also need to look, and this is something that I've looked forward to working with the president on, that we've not talked about, and that's something called pharmacy benefit managers. And that's the great ghost that the American public does not know anything about. These are the middlemen that are protected and created by insurance companies, which in my opinion are actually the biggest driver of pharmaceutical costs in the country. That, along with advertising, direct consumer advertising, are the two biggest things that I think actually we can actually have some purpose and some good movement in to decrease drug costs. Now, you can't, we live in a capitalistic society. The day we start doing price controls and price setting is the day when government overreach has really had its pinnacle. Yes, you know, you cannot condemn a company for making profits. You can't do that. Is it in the midst of the pandemic? Is that because people prescribed more drugs or did something else? I don't know. I'm not a Ph.D. researcher in that regard. I will tell you that the president is committed to lowering the drug prices in this country, and he will do in the next term efforts to make sure that. And be honest with you, I'll make sure of it. I'm going to be very, very forceful in that in my next term as a practicing physician, one who sees patients.
So Congressman, one of the most potentially robust interventions the president has proposed is indexing the price of drugs to what other industrialized countries are paying. I mean, that is essentially by proxy accepting government regulation of prices, isn't it?
That's indexing. That's indexing. That's just making sure that we're paying a fair price. We're not setting prices. We're indexing. There's a difference.
We're not setting the prices. We're relying on France and Germany and the UK to set the prices, and then we're just saying we'll take your prices.
That's right. That's
having other people's regulation.
That is his most favored nation construct, which he says we should not pay more than what those other countries are paying for, and that is, it's fine to say that, but he has no. He's not supported the legislation that would do that, nor does he have a specific policy to achieve that. Other than that, Noam, it's great. It's great. But to your broader point, to I think the congressman, is that is at least saying to the taxpayer and the beneficiary that we're not going to subsidize these pharmaceutical companies to charge whatever price they wish to the Medicare program. And I think we don't do that for physicians. We don't do that for hospitals. We don't do that for anyone in the Medicare program. But for some reason, we say, oh, if you're a pharmaceutical company, you can charge whatever you want to the Medicare beneficiary. That, to me, is no longer acceptable.
Well, Chris, I would agree with you. And there's been initiatives by the president to bring down the cost and affordability of both insulin and epinephrine for EpiPens and those things. So I would agree with you. There is no reason for them to be able to charge those things in that regard. But again, you know, we get back to the fact that, you know, it takes money to invest to put pharmaceuticals on the market. Sure. And unless we have folks that have profits to be able to pour those things into them, we won't see the cures. We wouldn't see the vaccines. We wouldn't see the type of interventions that, you know, my patients had kidney cancer that had spread 5 years ago. I had to go in and give them a terminal diagnosis. You can't do that. I don't do that now.
Sure.
I give them
Sure.
a good diagnosis, and that takes money, and
I,
that's where we can allow our companies to actually make a profit.
yeah, I can assure you, Congressman, that our country will pay amongst the highest prices of drugs no matter what, and they will make lots of profits to have investment and innovation. And that would be, by the way, something that would be a commitment that Vice President Biden would want to make too, because he's very sensitive to the adequate incentives for innovation across the board, but particularly in cancer drugs. And indeed, he supports a very significant infusion of more dollars for biomedical research within NIH too, to that end. So I just wish that, I think a lot of people talk about drug costs and their commitment to doing something about it, but I think what's happened with the public is they're so frustrated with hearing that we're going to do something and we don't. And I think that's one of the problems that the president faces, because he's talked about for 4 years and he has nothing to show for it.
So let's, we're rapidly running out of time here. And I do want to give both of you guys a chance to share any concluding thoughts and observations you may have. But I do want to give Rodney one more chance to jump in as well. And Rodney, I know I keep coming back to you to ask for sort of the reality check on what sort of is and is not possible. Clearly, both parties are expressing perhaps unprecedented interest now in addressing prescription drug prices. And yet, you know, as Chris noted, and the Congressman noted, we haven't seen a bill actually get to the president's desk. Have we gotten to a point where the pharmaceutical industry's influence may no longer be sufficient to hold back any kind of legislative effort, or is the logjam going to stay there, do you think?
Oh, I think there's something coming, but I think the what remains to be seen, and the conversations about how far we go are very serious. So start with the last couple of years. Between the House's H.R. 3 on the Democratic side, the Republicans' H.R. 19, the Grassley-Wyden bill, anybody who's worked this side of the street knows there's a deal there, unless you don't want one because you'd rather talk about the issue than a deal. And I'll cast aspersions on both houses and let them yell at me, fine. But I do think one thing that does need to get discussed at some point in a very rational way. Dr. Murphy has never been able to tell Medicare what he is going to get paid for his services. He's always been told what he's going to get paid. Okay, we know that manufacturers of pharmaceuticals have an incredible leverage, and we just watched in a hearing yesterday, the fact came out that one manufacturer literally raised prices on a drug to meet quarterly earnings targets. It's easy to put them under the gun for that type of behavior. But it's not wrong to ask a fundamental question before you take the first step, which is, how far is too far? We depend on remdesivir, whatever it is we're using right now as a treatment for COVID. That drug doesn't get developed without an expectation of return. And in my career, I was involved in the investigation of the marketing of the drug Sovaldi. And a fundamental question there that should be underpinning any action here is, how much is too much? If a gram per dose is too far, how much pressure can you put downward before the folks who are creating those drugs go, maybe the return isn't enough? Once you can actually have a legitimate conversation about that, then the policies can come forward that aren't just simply bloodlust because manufacturers do bad things, even when they do.
Good point. All right, we have about 2 minutes left. So how about 1 minute for each of you two guys to sell your guys' health plans for the next administration? And Congressman, you went first last time. Chris, why don't you go first this, and then we'll give the Congressman the last word.
Sure. Well, I don't believe there can be a better contrast for this election between two candidates than over the issue of healthcare. One candidate has sought for 4 years to try to dismantle, repeal, and invalidate the Affordable Care Act. Another one has sought to improve it and enhance it to address affordability and complexity for all Americans, not just people within the marketplace. He has a specific policy, he has specific initiatives, he has a long-standing history of working, by the way, across party lines to collaborate and get things done. And you know, when it comes to, I just have to say something that Rodney said. You know, he said that we have to have a balance, but there has to be some pressure, downward pressure on this drug prices, because it's not going to happen out of some sense of altruism by the pharmaceutical industry. So, and finally, I would just say on this issue, when he says there's a deal between the two, there's not a deal between the two if Senator McConnell won't even bring up the bill for a vote. So I'm a little bit, I think when you look at the differences between the two parties and the two presidential candidates, the choice could not be more clear on both healthcare and the better administration and addressing of the challenge that we currently face, which of course is COVID-19. And I look forward to the time where we can have a more rational debate by professional, competent people in and outside of government to address all these issues. And I have some confidence that we will be seeing that in January.
Am I good to go? Chris, I thought you and I had a rational, competent debate. Maybe I missed something. I think I think we agree on much more than we disagree in some regards. I come that from a point of having taken care of patients. I think the overall difference is the role of government. And, you know, it's one thing for Biden to make all these grand promises, but the same thing Obama did with Obamacare. And so many of those promises literally were empty or broken or not true. And yes, the president does have some initiatives that have not been enacted, and there are obviously things that need to get done. But it's the difference between the heavy hand of government, which I tell you has just come between me and patients, and we don't need more of the heavy hand of government. Are there areas to work in healthcare? By all means. Look at the growth of administrators over the growth of physicians. And that's because of regulation from government, that they have to hire more and more administrators to enact these regulations and to deal with these regulations. So adding more regulation, adding more government, in my opinion, is actually just the opposite way we need to go to control the prices of healthcare. And so there are initiatives that we can do. We walk over to CMS and cut a third of their rules, but that's an important thing that we do as we need to move forward. It's a difference of opinion on what our priorities are.
I don't know if you guys can still hear me. I'm sorry, I lost my video, but if you can, thank you both very much for that entertaining and hopefully enlightening discussion. And I'll turn it over now to Michael, whose internet hopefully will be better behaved than mine. So thank you all three.
Thank you, Noam.
Thank you.
I think I'm showing, so thank you all, and thank you, Chris and Rodney and Congressman Murphy for taking the time to share your perspectives and expertise today. We touched on some tough but very critical areas of health policy. I think this has been one of the best conversations on healthcare that I've seen recently, so we really appreciate it. We touched on some very top priorities for NCHC members, and so thank you so much. As we transition panels, I'd now like to introduce David Sertner to give some remarks for AARP. David is the Legislative Counsel and Director of Legislative Policy for Government Affairs at AARP. He has represented the organization for over 3 decades and is a member of AARP's leadership team. He currently serves as counsel for the association's legislative, regulatory, and policy efforts, as well as litigation opportunities before the courts.
Okay, great, thank you. So let me give you a quick overview of some of AARP's top health concerns. Right now, we are obviously focused on the pandemic, and particularly the needs of residents and staff in our nation's nursing homes and other long-term care facilities. Nationwide, over 80,000 residents and staff in these facilities have died due to COVID, over 40% of all COVID deaths. That's the equivalent level of deaths of 30 straight weeks of the Twin Towers coming down on 9/11. What is happening in America's long-term care facilities is a national disgrace and an ongoing tragedy that must be addressed. Every day of inaction, hundreds more die. And with the flu season approaching, the risks for residents and staff will grow. AARP has called for immediate action on a 5-point plan to save lives and improve conditions in these facilities. We need to, 1, ensure regular and prioritize testing of staff and residents and provide the necessary PPE. We need to require transparency around COVID cases and deaths, and we need guardrails to ensure that funds that are being used for testing, PPE, staffing, and other items that directly relate to resident care and treatment. We need 3, to require facilities to provide and facilitate virtual visitation, even as some of the in-person visitation resumes. 4, we need to ensure adequate staffing levels and ensure that long-term care ombudsmen have in-person access to do their jobs. And 5, we need to reject blanket immunity for nursing homes and other long-term care facilities related to COVID. Reports indicate that PPE is still not always available or used properly, and that testing varies widely. Results take too long to come back. We must prioritize help for these facilities where there's been such a disproportionate loss of life, and we need robust, dedicated funding with transparency and accountability. The devastating impacts of COVID in these facilities has also demonstrated the need for greater investments in home and community-based services. These investments will allow more older adults to age in their homes and communities where they want to be, while also helping to alleviate some of the challenges we're facing in our nation's nursing homes. For every 1 person residing in a nursing home, Medicaid can fund 3 individuals receiving home and community-based care. ARP has long urged sufficient resources to enhance access to HCBS, including support for the workforce that provides the important services. Especially now, when so many people are seeking alternatives to congregate care settings, we must make HCBS a higher priority. Another priority, as we just discussed, for ARP is high prescription drug prices. American seniors and taxpayers should not have to subsidize lower prices in the rest of the world by paying the highest prices here in the US. There are many ways, both large and small, to address the pricing practices of drug companies, including things ARP supports, such as allowing Medicare to negotiate prices and moving to an international pricing index. But as more higher priced drugs come to market, this era of unrestrained pricing must end. Also back in the spotlight, of course, is the ACA. For older Americans in particular, that includes its key protections for those with pre-existing conditions and the limits on unaffordable pricing based on age, or limits on age rating. While I remain somewhat optimistic that the legal argument before the Supreme Court is so weak that the ACA will survive this latest legal challenge, no one can really be certain. And if the unthinkable happens and the healthcare system will be thrown into chaos again, chaos seems to be the word of the week, and once again we'll need a national debate on fundamental healthcare reform. But even if the ACA stands, there are still many issues of coverage and cost that we'll need to revisit. And finally, we will need to strengthen the Medicare program. The current recession has likely moved the solvency date up, potentially to the end of the next president's term. Medicare coverage, of course, has been critical to older Americans, particularly during this pandemic, and medical will continue to be critical as we hopefully develop and distribute a vaccine. There's not only the need for science-based safety and transparency, but there are logistical and practical hurdles that must be overcome to ensure that the most vulnerable older population is protected. And I hope this brief overview provided some helpful insights on the key issues that ARP is focused on right now in the coming months. And with that, Michael, let me turn it back over to you.
Thank you, David. And thank you for turning our attention to those high priority issues. You spoke about a lot. NCHC is focused always on the key threats to affordability and access, which you mentioned. You also brought up, I think, an important point about disparities. And I think our second panel will be talking about that quite a bit. So thank you for all of your work. I'm now going to introduce the moderator for our second panel, Licy Canto. As Executive Vice President and Managing Director in BCW Public Affairs and Crisis Practice, Licy drives healthcare and social impact policy and strategy and helps shape strategic direction on diversity, inclusion, and belonging for the firm and its clients across North America. Licy also leads the BCW healthcare team in Washington, so welcome, Licy.
Thank you very much, Michael, and thank you to the National Health Coalition for Healthcare. What a great discussion that we've just had and great remarks from ARP. I want to take the conversation now to look at beyond just the election and look at the future of healthcare. And that's what we're going to be discussing today, not just the future of healthcare, but that healthcare system as the nation grapples with COVID-19 and the pandemic and the civil unrest of systemic racism and an upcoming election. COVID has touched and impacted essentially every aspect of our healthcare system, putting an immense pressure on our hospitals, on our healthcare workers, on our supply chains. It's stripped away many of their healthcare coverage along with their jobs, and it has affected communities and people, especially vulnerable communities and communities of color, with mounting fatalities. By stressing the known weaknesses in our healthcare system, the twin pandemics of both COVID and systemic racism forces the critical question: is our system prepared to address the healthcare challenges that lie before us? And is this system working for everyone? As we look at these questions, we're forced to ask ourselves at this moment in our country, how much of our healthcare system needs to change? Do we need to reinvent it? Do we need to rethink it? Do we need to re-engineer it? Do we need to reimagine it? And if so, what should be the broad contours of this reimagination? We're in an extraordinary moment, and in thinking about this question, and really the question of how we should reimagine the healthcare system in a way that lays a foundation, not just for a more resilient, equitable, and innovative healthcare system for the years to come, but a system that is better for all and works together to become far more than just the sum of its own parts. I'm excited to be joined by an impressive panel of brilliant minds and leaders in our healthcare system. I want to introduce them now. First, Dr. Anand Parekh. He is the Chief Medical Officer, Chief Medical Advisor for the Bipartisan Policy Center. BPC is a Washington-based think tank that actively fosters bipartisan ship by combining the best ideas from both sides of the aisle to promote health, security, and opportunities for all Americans. Welcome, Dr. Parekh. Next, Dr. Elena Rios. She is the President and CEO of the National Hispanic Medical Association. NHMA represents 50,000 Hispanic physicians in the U.S. and works to improve the health of all Hispanics and Latinos across the country. Welcome, Dr. Rios. Next, Matt Salo. He is the Executive Director and of the National Association of Medicaid Directors. NAMD represents all 56 of the nation's state and territorial Medicaid directors and serves as a unified voice for these directors in national discussions on healthcare. Welcome, Matt. And then Dr. Beverly Malone, who also is a nurse. She is President and CEO of the National League for Nursing. NLN is a national organization for nurse educators and offers professional development, teaching resources, research grant testing services, and public policy initiatives to its over 40,000 individual and over 1,000 institutional members. Thank you very much for joining us, Bev. And Dr. Sachin Jain, President and CEO of Scan Group and Health Plan. Founded in 1977, Scan Health is one of the nation's largest non-for-profit Medicare Advantage plans, serving more than 220,000 members in California. Thank you very much, Dr. Jain, for joining us today. I want to jump right in and ask all of you, starting with you, Dr. Jain, a question to set the tone here. Dr. Jain, Sachin, tell us where you grew up and give us your brief perspective on how you think attitudes towards healthcare and healthcare system have changed since that time.
Thank you so much. Really appreciate it, and honored to be here. I grew up in northern New Jersey. I was the children of immigrants, the first in my family to be born here. And I can tell you, I grew up without a sense of true belonging. I believed my otherness was reinforced almost every single day. I grew up in a relatively privileged community. My father is a pain management physician. But at the same time, I didn't necessarily feel like I was part of American society in the way that I think others might. And what I'll say is that otherness has stuck with me throughout my life. And I think about it a lot in the context of our healthcare system. The reality is that there are many people who are members of American society who don't feel like they're part of American society. And I would say the healthcare system has a way of reinforcing it. We reinforce it by not necessarily providing care in one's language. We reinforce it by not necessarily recognizing the cultural nuance that people have in their approach to living, in their lifestyles, and the ways in which they need care. And then I think we reinforce it by the divisions in terms of how we actually deliver care in this country. We have a evolving ratings and ranking system in this country that ultimately rewards organizations that perform better. But the dark side of pay for performance is that we're not necessarily looking at the social obstacles that exist in some communities to achieve, the outcomes that receive the better rewards. And so I think we have a lot of work to do, systemic work to do, cultural work to do, to drive greater health equity and greater considerations of health equity.
Thank you, Sachin. Dr. Elena Rios, Elena, I want to ask you the same question. Tell us where you grew up and give us a brief perspective of how you think attitudes on healthcare and the healthcare system have changed since then.
Thank you, Licy. It's an honor to be here and exchange information about the future. So let me start with the past. I was raised by a machinist, my father, and my mother, a housewife who eventually became a nurse. Both of them came from Mexican-American parents who had been, their parents, my grandparents, had been undocumented travelers to the United States who became citizens. All of my uncles, aunts, cousins, et cetera, are in the Los Angeles area. And I grew up in the 1960s in white neighborhoods, believe it or not. My parents were able to buy a house in the late 50s in Pico Rivera, which is now 99.9% Mexican American, but at the time was white. And I think what convinced me about the importance of healthcare was growing up, we had insurance. Factory workers had insurance. But growing up, we realized we didn't have dental insurance and there was no vision insurance. And so you got to, as a family, got to understand a little bit about the dynamics of, and being a big five kids, being a big family, got a chance to see the dynamics of not having enough, being lower middle class. You know, we didn't consider ourselves poor because we had layaway plans and credits at the local grocery store. And people supported each other, I think, a lot more than we think in our families with our aunts and uncles and cousins helping to pay the home taxes, that type of thing. But anyway, let me move forward. I went to Stanford University and met a whole new group of friends like me, were from first in their generation to go to college, had a real sense of commitment to our communities and understood that we had to help ourselves find out how to make change. And I think that for the future of healthcare, finding healthcare change agents, catalysts, leadership is one of the most important things that we can do in our communities. And we happen to be Latino medical professionals. We work with our Hispanic nurses and our Hispanic dentists. You know, when I went to high school, my mother was in college, becoming a nurse and working in the hospitals, local hospitals. And I met doctors and nurses. So I wasn't afraid of trying to jump into that world. But so many of our families don't have the connection, the role models, the mentors. And I think if we're going to change the healthcare system from a diversity perspective, we have to do it ourselves. And what I mean is the Hispanic health professionals, the Black health professionals, the Asian health professionals. I mean, we all have to do our own efforts to really build that leadership and promote and hire those who can be the leaders of the future.
Thank you very much, Elena. Dr. Parekh, I want to ask you, tell us where you grew up and give us an idea of how you think attitudes towards health and healthcare, the healthcare system, have changed since then.
Or Licy, thank you, and it's great to be part of this panel. You know, I grew up in Michigan, son of mother was a physician, grew up with a lot of healthcare professionals around me, went into clinical medicine, but really wanted to make a change at a broader level and got into population health and public health. And, you know, I spent the first part of my career, I would say, taking care of patients. And then from a policy perspective, you know, focusing on individuals with multiple chronic conditions. And I think we've seen that across the country now, you know, 4 in 10 adults with multiple chronic conditions. And I think over time, I think what I've realized is that so much of what we end up treating or focused on is in fact preventable. And prevention in many ways needs to be our nation's top health policy priority. And we don't prioritize that. And I think and there are many reasons for that. You know, to focus on prevention, you got to be proactive and not reactive. It requires patience. Sometimes wins are invisible. We obviously don't spend the resources we need on prevention. But I think over time, I think what I've realized is as we focus so much on downstream healthcare services, you know, we've missed the midstream, the upstream piece. You know, we haven't focused on improving population health through public health and primary care and prevention. Haven't focused enough on social services. And I think I've learned that throughout my career. I think that, you know, I think more and more people are understanding that that's going to be critical, also to solve some of our most pressing healthcare challenges. So that's sort of my perspective, how I've also evolved from where I started. And I think I'm sure we'll talk about COVID-19 more, but sometimes it takes a crisis to once again remind us how much we take for granted and where we need to go. And I think prevention in some of these areas are really where we need to go.
Thank you very much. We're going to get to COVID in just a moment. I want to ask Bev Malone, tell us where you grew up, give us a sense of what you think, how you think attitudes towards healthcare and the healthcare system have changed since then and in your lifetime.
Well, I grew up in Kentucky, and it's right at the Mason borderline, but it's really in the South. And at the time, it was totally segregated. So all the white people lived on one side of the railroad tracks and all the black people lived on the other. And I lived on the other side of the tracks. I had never been in a hospital because we were warned, you don't go to hospitals. They don't treat you very well in there. They may do interesting studies on you if you go into a hospital. You may never come out if you go into a hospital. And so when I was growing up, we never went to hospital. When I got to be about 16 or 17 and I was in a school that had by that time been segregated, I joined a nursing club. And I did because my great-grandmother who raised me was the community healer. And she always wanted me to be the real thing, a nurse. So I joined this nursing club and I actually got to be a candy striper in a hospital. So I saw healthcare from there, but it was still very segregated healthcare. So now I look at us now and I'm thinking that in many ways we haven't changed, and that right now people are afraid to go into hospital because it's frightening because of COVID. And so what do we need to do differently? We need to understand that we need a public health system structure. We don't have a public health structure. We tore it down 20 years ago or something. We didn't fund it. And so we need a public health structure. One of the things I do remember is the public health nurse chasing me up a tree in order to give me my vaccinations. So I think that they may be very effective people if they can catch me up a tree. And nurses are I'm a nurse, and so I think we're just about as wonderful as the day is long, that we are very much in need of making sure that we have enough people of color within our workforce. And that is something that has not, right now it's about 8%. And that's African American. Overall, it's about 13% if we look at all of the different people of color in nursing. And while that sounds better than some of our other professions, it's not good enough. That we really do need to focus more on how we can make sure that there is enough people of color delivering the care, because the burden of care is more on people of color than it is on others. And so we need that workforce to match some of that. I believe wholeheartedly that we are going to be looking in the future, and we are right now. We've discovered telehealth, and I'm thinking it's been around for about 20 years, but we have not used it effectively, and we have not had access to it. And the rules and the regulations don't allow us to sit in one state and do something in another state because of all of our different rules between the states. And I think we're going to have to give up on some of those rules and regulations in order to make sure care gets delivered, not just in the place you live, but gets delivered all across the country. I'm thinking that all of that's going to be necessary, and that's a reimagining. And it's funny when you reimagine that sometimes you take things that have been around a long time and you just put them into place. There needs to be more hospice care. That is not because we have a COVID, that's just we need more hospice care and people understanding how to give hospice care. And when I think about nurses and the workforce, I think about faculty. I'm the CEO and president for the National League for Nursing, and I can't help but think about you can't teach what you don't know. And so if faculty are not prepared, then the nurses will not be prepared. So there has to be a focus on faculties, whether that's in schools of medicine, schools of dentistry, schools of nursing. Faculty teach the way they've been taught, and we need to help them out of that syndrome. They need to teach more what they're learning and what they need to know about this new world that we're living in.
Thank you very much, Bev. Matt, I'd like to ask you the same question. Where did you grow up, and how have attitudes towards health and healthcare changed briefly since that time?
Sure. Thanks, Licy. I have, I guess, probably the least interesting backstory here. Unlike everybody here, I'm actually living in the town where I grew up, Alexandria, Virginia. Didn't make it very far. I don't know if that's just the lack of ambition or whatever. Also, unlike the panel, I'm the only one who's not a doctor. In fact, I never got beyond a BA in Eastern Religious Studies. So, you know, I don't know what that tells you either. But I have spent my entire career, so that's 27 years now, working on behalf of the state government officials, either state Medicaid directors or governors. And the one thing that really stuck out for me and has kind of kept me in the mix from day one is just how passionate and committed and yet pragmatic the folks are that have to run these programs. And their job description, and this has been true for 27 years that I've been around, no matter where you are, the job description has always been to try to provide the best possible healthcare, to improve the healthcare experience for the people that they serve, while doing so with an unreasonably constrained budget, but also having to do so within the political and the cultural parameters that are relevant in that state capital. And again, that kind of really drives that mix of compassion and practicality that I've always found really, really refreshing. And I guess the thing that I reflect on that has really changed, you know, when I first got started, you know, I remember, well, I didn't know what Medicaid was. I'm still not sure my parents know what I do. They still say Medicare every once in a while, and I just kind of shrug it off. But, you know, I think 20 plus years ago, very few people really did understand or appreciate what it was and what it did. And to reference back to our good friend Rodney Whitlock, I remember him telling me years ago, when he would talk to the senators in the finance committee, they would he would joke and say, because he did Medicaid, he would say Medicaid, and they would look at him and say, is that the one for old people or the other one? And so I think we've been the other one for a long time, but I think that really has significantly changed. And I think there's whether it's, Medicaid really being on the front line for the response of every natural or man-made disaster or emergency we ever had, to being the largest insurer in the country, the largest payer of long-term care, covering 50% of the births in this country, the largest provider of mental health services. It's big, it's important, and I think people are really starting to recognize that. And I think that's something that's really important to build on as we move to the future. It's how do we recognize the critically important role in society that Medicaid plays, support it so that it can continue to get the job done, but not actually overburden it by asking it to do too much. And I'm sure we can talk about all that more later.
Great, thank you all very much. I think our audience has a very good understanding of the background and the evolution of your perspectives. I want to jump right in because I want to get into affordability and coverage, healthcare inequality, of course, COVID, technology, and so many other issues with the time that we have left. Let's first start with affordability coverage, and I'm going to ask you, Sachin, to answer this along with others who want to comment. So a core kitchen table conversation that's going on right now as a result of COVID, but it's been going on for a long time, is affordability and coverage. People have lost their jobs, they've lost their insurance, small employers have been hit hard. This week, Reed Abelson in the New York Times wrote, losing coverage in the middle of the corona crisis, as millions of other Americans have, was like going into a thunderstorm without an umbrella. As we reimagine this healthcare system, what is it that we need to think about in terms of the issue of affordability and coverage? Sasha.
You know, I think it goes back to Anand's comments, Dr. Parekh's comments about kind of a greater focus on prevention. We have to look at why healthcare has ballooned in terms of its expense for this country. And it's not because it's producing better outcomes for us. We know that. The reason it's ballooned is because there's an increased utilization of services as people develop more and more complications from otherwise preventable clinical diseases. And so things like hypertension and diabetes, which are relatively inexpensive to treat upstream, blossom into diabetic retinopathy and kidney dialysis and end-stage renal disease as they progress further along the continuum. So I think we have an opportunity as a country to rethink, how our focus in terms of our delivery models on models that incent and promote prevention and actually treat people early on in their conditions, as opposed to, spending significantly on what are otherwise preventable complications. We spend a lot of energy talking about drug costs. We don't spend a lot of energy talking about, how we can actually avoid the need for those drugs. We spend a lot of time talking about why insurance is expensive, not necessarily looking at the underlying drivers of why insurance is expensive, which is that people need hospitalizations that they shouldn't necessarily need. And so I think we should, total costs is a function of the quantity of services delivered as well as the price of the services. And I think a lot of people spend a lot of energy talking about the price, but not a lot of energy on the quantity of services. And so, I think we need a reimagination, to borrow Bev's expression, of what good healthcare looks like. And good healthcare looks like a greater focus on prevention, upstream management of chronic disease, and creating the social conditions where people can live healthier lives longer. And that's a cultural question as much as anything. And the reason we don't talk about these things is because they're hard to talk about and they're hard to change. But that goes to my, I think, fundamental thesis is we need real leadership in our industry, and leadership that focuses on the hard to solve problems, as opposed to just having the usual conversations that we have about coverage and quality and access. I think we need a full reframing of the discussion.
Thank you. Dr. Rios, very briefly, what do you think as we think about reimagination for the future, what should be doing around the issue of affordability and coverage as Sachin has just talked about, very briefly?
I'll just follow the content, the train of thought here. I was asked to help with looking at the dietary guidelines. And do you know that the dietary guidelines could actually focus on patients with diabetes, or patients with heart disease, or patients with, obesity, instead of just saying, eat this or eat that? And I think that it would talk to our communities better to help them understand that the guidelines of this country wants to help you be healthy. And I do think that it is a community-based effort that needs to happen. It has started with, farmers markets and having vouchers with the SNAP program, for example, to school lunches, after school programs, summer school programs in terms of meals. So just in terms of the reimagination to cut costs and to provide people with more prevention activities, not just education is especially education and action, I think, is needed. And I also think at a community level, we need to have partnerships that go beyond the big hospital academic health center doing research. I think the doctors need to be involved, the nurses, but more importantly, our public health infrastructure needs to be all the way down to the local level like it used to be. We used to have community clinics that were public health. And I think the public health infrastructure got changed with the notion that we shouldn't do services anymore. Let that be the market, the private sector, and public health became just data collection and surveillance. So I think that we do have to look at what we have in terms of our programs with nutrition, physical activity, the basic public health prevention type programs, diabetes, heart disease, cancers, and build programs that actually reach the communities before they get worse and they develop complications.
Thank you. Anani, of course, you recently wrote a book all on the issue of prevention. Your thoughts very briefly on affordability and coverage. What should we do as we think about emerging from the crises that we're in now and looking into the future?
Well, I think like Sachin and Elena, I would stay broad because I think even when you're talking about affordability and costs, it comes back to the bigger picture. And when you think about reimagining, you have to look at where we spend our resources. And the fact of the matter is, our $3.8 trillion health expenditures in this country, less than 3% go to public health, less than 5% go to clinical preventive services, and only 6 to 7% go to primary care. And those three buckets are not mutually exclusive. So at some point, you got to call the question, where you spend your resources define your priorities. Your priorities define your value. The question before us is how healthy of a nation do we aspire to be? When you look at the healthcare to social service spending ratio, it's the same way. Our social service to healthcare spending ratio is about 1 to 1. Most comparable countries in the world, it's 2 to 1. If you look at states in this country, the higher social services, the healthcare spending ratio you have, the better health outcomes you have. And so I think one way to go about it is we need more of a social infrastructure. We need to invest in social services in this country. That'll help on the healthcare side. And then we need to spend the $3.8 trillion we're spending on the health side in a way where we're tackling those midstream social needs and those upstream social determinants. So some of this, Licy, I think when we talk about reimagining, we need to sort of take a step back. And I think we need to bring in some of these things that we don't talk about, because at the end of the day, they do ultimately affect affordability and the cost of healthcare.
Thank you. Bev, Dr. Parekh says, step back and let's take a look at what we need to do to reimagine. What do you think about affordability and coverage, particularly given the 40,000 plus nurses and others that you work with?
Well, I work with 40,000, right? Those are faculty members, but there are about more than 4 million nurses in the country. So there is a nurse everywhere. And most of us are committed to prevention, as has been talked about, and that's what has to be discussed. But prevention has it has so many intersectionalities around. It's got to be about where you live. I think someone mentioned that. It's not just about, oh, you can't eat that or you can't do that. It is about who you work with, where you work, if you have the opportunity to work. Those are all important issues. I'm thinking that I would just like to take Medicaid from my colleague down there and expand it so that healthcare becomes a right and not a privilege. If I were going to reimagine it, I want to make sure everyone has core basic healthcare. And that would mean that we would be working with a preventive model from the beginning for all. And we've spent so much money during this COVID time and during this period of a couple of years that I think we're quite in debt nationally. That's my understanding. It would seem like we could have taken that money at the same time and made sure that everyone had health care, and that would make a grand difference in terms of how we are experiencing the COVID virus right now.
Thank you very much, Matt. Of course, Medicaid and the work that you and those that you work with have been addressing affordability and coverage issues for many years. Very briefly, what's your thought?
Yeah, so just a framing that affordability and cost within the Medicaid context is very different than for everybody else, because for the actual consumer, for the actual individual, the beneficiary, the costs are essentially zero. There's no premiums, copays, deductibles, that sort of thing. And so it really just becomes a cost to the state and to a certain extent the federal government. I think though that it's pretty clear that if I'm doing some rethinking or reimagining of what the future holds, I first look at, well, what has the last 55 years done? And the last 55 years have taken Medicaid from an afterthought into a behemoth, like I said earlier, the largest health insurer. It is a $600 billion a year program, and it does so much more than it was ever designed to do 50 plus years ago. And I think the challenge is that, and certainly during the pandemic, this pandemic, every other one, during this economic downturn, like every other one, Medicaid's costs and enrollment are going to grow. It has done nothing but grow. I think on some level that's a testament to how successful we have been in solving all of the other problems in the healthcare system or society writ large. But I would really challenge us to sort of step back and say, is this really sustainable? And I think the answer is no. And I think that a couple of the really huge cost drivers that we're going to have to confront before too long are the fact that Medicaid is the nation's long-term care system. Medicaid has an outsized role in subsidizing the Medicare program, which, you know, really isn't very meaningful for people who are very, very sick. And as we ask it to do more and more and more, the tax base at the state level, I don't know that it's there. So one of the reflections that I would share, and again, we're not that far removed from the efforts to repeal and replace and block grant the whole program. We're not that far away. But one of the things that our members really reflected on during that time was, you know, Medicaid is really good and Medicaid is really important, but we can't keep asking it to do everything. And in an ideal world, Medicaid would be less necessary. That there would be other, you know, maybe Medicare is relevant for the dual eligibles. You know, maybe private coverage actually provides mental health benefits so they don't all end up on Medicaid. Maybe employers cover families so we don't cover 50% of the births. Right. We've got to look at those other things. Right. And to build on the other thread that everyone else picked up on, it's all of those other pieces that aren't traditional insurance, housing and food security and adverse childhood events, the social determinants of health. Those are all so important. But I don't know that we can look to Medicaid to say, you pay for it all. Right. That's the challenge.
Thank you very much. We have about 15 minutes left. I want to turn now to healthcare inequality, look at it squarely, and go to you, Sasha. You've been doing a lot of work in talking about this, as everyone here on the panel has. We know that COVID and civil unrest around systemic racism has brought to the forefront in brutal fashion the long-standing healthcare inequalities and inequities that exist in the system and in the country. How do you think the pandemics are changing how our healthcare system should be addressing inequalities in care now and in the future?
Yeah, I would say COVID-19 has been a stress test for our healthcare system and how well we do with kind of social health equity. And I would say that as a country, we've failed that stress test. When you look at who has been disproportionately affected by COVID-19, which communities have had disproportionately poor outcomes as it relates to COVID-19, it's been, you know, low-income individuals and African-American communities and Hispanic American communities all over the country. And if that doesn't tell a story of, you know, unequal distribution of resources, I don't know what really does. My biggest concern about the convergence of the COVID-19 epidemic, as well as, you know, the kind of burgeoning view of our social inequality that really came out of the George Floyd shooting, is that we have a lot of organizations that are putting a lot of lip service out there about how much they care about these issues. When we've made it too easy for organizations to kind of stop at a carefully worded PR statement and leave it at that. And very few organizations are taking a very hard look at their own operations and the own ways in which they maybe reinforce health inequalities. When I look at SCAN, which we're very proud, we've been a 4.5-star Medicare Advantage health plan for 5 of the last 6 years. I look at that rating and I say, did we potentially achieve that rating by not necessarily serving people in communities who would benefit from our care and our service? Because it's easier to achieve those ratings by actually being present in communities that aren't necessarily hard or difficult to serve. I think the bar has been raised. I think the bar is going up. I think we all have to do better. We all have to perform better. And we all have to ask the hard, uneasy, uncomfortable questions of ourselves around, what could we be doing more? There was a story in Bloomberg about the Cleveland Clinic on the heels of the debate and the grave health inequalities that exist in Cleveland around this, national mecca for medical care and service. I don't know enough about what was there, but it raises this question that I think, that exists in every community in America, which is, why is it that the best healthcare systems in the world are surrounded by communities that ultimately have terrible outcomes? And so we have to do more. We have to think differently. We have to reinvent our delivery models. And I think COVID is just shining a light on what many of us have known for a long time, which is that, even though we have one of the most advanced, healthcare systems in the world from a scientific and technological innovation perspective, I would say we have one of the most regressive healthcare systems of the world when it comes to, equity and distributive justice.
Anand, I'd like you to bring that in. Thank you very much, Sasha. Very briefly, how do you think the pandemic is shaping how the healthcare system should address inequities and inequalities now and moving forward?
I agree. I think it's a stark reminder that these are issues for too long that we have not paid enough attention to. It's health inequities driving the disproportionate number of cases in communities of color, and it's health disparities driving the disproportionate number of deaths in communities of color. And I think for too long in the healthcare sector, working on these types of issues were things that we did on the side. We'll work on health disparities here and we'll do a little bit there. But I think what is being reinforced with COVID-19 is that's got to be the central piece of what we do, because the main challenges we're going to face as a country, as a healthcare system, we're not going to be able to solve any of those challenges if we don't squarely focus on some of these issues related to disparities and inequities. And I think it's a lesson that we should have learned prior to COVID-19. But I think for many, hopefully what we should realize is that this can't be sort of a side issue or a side project. It's got to be a key core part of what we do, not only because it's important in and of itself, but that's an important way that we achieve some of our broader healthcare goals.
Thank you. Bev, I want to look to you very quickly. How should the healthcare system be thinking about re-engineering how it responds to healthcare inequities and inequalities, as Dr. Parekh and Dr. Jain have said?
While my two colleagues were talking, I was thinking that the real message is that my health care is dependent on your health. My health is dependent on your health. I can only be as healthy as you are. And you may be a person of color. Boom, that's the difference. We thought we could put a railroad track and that would separate. So we thought we could put something else to separate, and that was it's the gates, the gates with the keys and the men standing at, so there was supposed to be all of these barriers that were separating the healthy and wealthy, but at least healthy, and those who are not healthy. And it doesn't work like that. And COVID says that so clearly, that sorry, it's in the air that you breathe. And while it does affect people of color, communities of color more, it still affects those who are not of color. And so it becomes a national problem and not just a community of color problem. And I think that is public health. My health is dependent on your health. That is really public health at its best. And I'm thinking that we've got to grab hold and embrace the principles of having a healthy nation, and that we're all interdependent. And that means we have to have a healthcare system that addresses all of us. And while I know that this may be lip service in some areas, I'll take it. It's an opening. It's the opportunity to reimagine. It's at least we're even having the conversations that we never had before. So it's like, don't get discouraged. I would say to my colleagues out there that you may not believe that, oh, are they really believing what they're saying about looking at the structural racism? Take it and go with it. This is an opportunity to make a difference. It's an opportunity to reimagine. This is an open door. Walk through the open door.
Thank you. My health is your health. Matt, what does that mean in the Medicaid context?
Yeah, no, I think that this is all correct, and I think that's part of our challenge, is to figure out how does the Medicaid program and the kind of the public health infrastructure, which is, as has been alluded to, underfunded, underutilized, strained beyond capacity. How do we do a better job of combining and integrating the two, not just during a pandemic where it's painfully obvious, but beyond, to help prevent and ameliorate the next one. But I would really also just kind of stress, and Dr. Malone, I really appreciate your point about, look, let's find the doorways when they open, let's take advantage of them, and let's get through them as aggressively as we can, but hold ourselves accountable. And to Dr. Jane's point, it can't just be a check the box and we're going to ignore it. Right. It's both, and I think that's important. And from my members' perspective, because Medicaid is by definition a means tested program, we have an overrepresentation compared to the nation at large of communities of color. And so there really is an obligation on our part to do something about this. And as my members are thinking about their lives and their work these days, there isn't a single conversation that we've had in the last 7 months that hasn't been through the lens of either the pandemic, the economic downturn that was precipitated by it and is going to be long lasting and painful for all of us, and then the racial and ethnic inequities and disparities in, again, not just in Medicaid, not just in the healthcare system, but really in society writ large. Everything is connected to those things. And it is absolutely our extreme motivation to try to figure out, because this was like a slap in the face to say, this has really been a problem longer than just 6 months ago. We haven't confronted it. We really have to now, and we're going to.
Right. Dr. Rios, how do you and the 50,000 and many more Hispanic Latinos that you work with in the healthcare space, how do you think the healthcare system should be addressing these inequities and inequalities? And very briefly, we are coming to about 5 or 6 minutes left.
Right. I think the important thing for Latinos who actually are in the health professions, and we work with doctors, nurses, dentists, public health leaders. We actually have a network of Hispanic health professional leaders. And it's so important to realize they're the first in their families. The higher level they go up in their careers, the more isolated they are. So what they need is mentoring and leadership development in order to fulfill their dreams of helping their families and helping their communities. So I think one of the most important things that we can do to help the healthcare system reimagine itself is by being appointed to boards and advisory committees of our own hospitals, and I'm talking community hospitals, academic hospitals, as well as institutions that are part of the public health structure, talking to our communities, because that outreach and those educational programs have not been designed by the community. It has been designed by people who don't come from communities. And I think that the other important thing about healthcare for the future is that we do need a sense of change, but also of accountability. I'll give you an example, clinical trials. We're headed toward, we have clinical trials right now for COVID-19. And we are seeing an uptake in the minority patients being focused on, that's great. But how many Hispanic or African American principal investigators are there getting the funding to do clinical trials? Because they always go to the same large health systems instead of incorporating a sense of diversity and so that we can have health equity. So I think diversity is a major problem within the healthcare arena that needs to be looked at more, more aggressively, and open the door. As Bev says right now, we have this opportunity to really be more aggressive with health equity policies and diversity especially.
Right, thank you. I know there's a lot more that we could talk about, including the workforce and the heroic work that the healthcare workforce is doing, from the frontline workers, the nurses, the clinicians, but also those who keep our health systems clean and those who feed our patients, and also technology, as many of you mentioned before, the revolution, the inevitable revolution in telemedicine and the use of big data and AI to improve care delivery and decision making, and of course, never before, I think, in our lifetime have we seen so many of the world's researchers focus on one single issue. I know we could talk a lot more about that. I want to ask each of you this final question, as we have now about 3 minutes left. We all know that we're facing not just a national, but a global crisis, whether it's in COVID, whether it's in systemic racism, whether it is in the many other crises that are unfolding as a result of the impact of the pandemic. And the decisions that you and other leaders in healthcare, as well as policymakers, will make in these coming months are going to shape the healthcare and healthcare system in our country for years to come. So I want to ask each of you, starting with you, Dr. Jane, what do you see as the action, decision, innovation you think will have the biggest impact in the months to come, in terms of having the kind of change that we've been talking about here today? What does that look like for you? And for 30 seconds, please.
I think we're in the darkness before the dawn. I think we have more kind of consensus and more recognition of the problems in our healthcare system than we've ever had before. I think one of the challenges that we've historically had is we've never had kind of alignment on what the issues are. I think the issues are now super clear. So I have greater optimism that they're going to be solved, cost, affordability, quality, everyone's feeling the pinch of them. And I think the fact that it's so broadly distributed means that I have greater optimism than I've ever had before that we're going to come to some solutions.
Thank you. Thank you very much. Dr. Parekh?
Let's learn the lessons that come out of this crisis that we're in right now. And that's everything from making sure we focus on health inequities and health disparities, making sure we invest in a public health infrastructure and a public health system, making sure that we fund and support the social determinants of health. Right now, over the next couple of months, we'll have millions of people might not be able to afford rent. 1 in 6 adults who might not be able to get food. Those things really matter. And also, I think on the healthcare side, so many practices that are just getting by over the last few months. And that's an important message, that we need to accelerate value-based healthcare transformation. We need to get the metrics right, but that's really important to sustain, I think, healthcare in general.
Great. Thank you very much, Dr. Parekh. Dr. Rios?
I think the importance of coordination of care is something that has been brought to the forefront, especially on the payer side. The issue of that's a technology, and that needs technology. That needs data collection with race and ethnicity data that I think needs to be more mandatory than anything. And I think that coordination of care helps the system follow the patient along the continuum of care. And I think that's something that we really haven't done much before. You go in a hospital and you were discharged. Okay, maybe you had a visiting nurse. But now there's the opportunity to have telemedicine, telehealth, more nursing, more hotlines, more text messages for babies, has been a model program. And I think that coordination of what we have through technology, all these technologies need to be increased. And I have to say that for Latinos and African Americans and poor people, there still is a very big digital divide. So we need access to internet that is affordable and computers in our families.
Thank you very much, Dr. Rios. Matt?
Well, sorry.
Yeah,
Go ahead.
Matt, and then Bev, I'll ask you to close. Thank you.
I guess real quickly, I resonate with all the things that were just said, and Anand really stole my point around, this is the need to really focus on value-based purchasing. Because if there's anything that the pandemic has showed us, it's that, an uncoordinated, unmanaged, purely fee-for-service system isn't gonna work. We got to do something. But let me pivot the question a little bit and say, if we're going to talk about the future, if we're going to have a future for Medicaid and the healthcare system in this country, we've got to get through the next couple of years. And we are not going to get through the next couple of years if there is not a decisive and protracted effort from Congress to help support and stabilize state governments, the Medicaid program. Because if that does not happen, then what we're going to see is Medicaid costs continue to go up and up and up, at the same time that state general revenues are going to go down and down and down, at the same time that schools, as we've alluded to, and daycare centers are going to need more and more money to open and open safely. There's no money to do all of those things or any of those things. States have to balance their budgets. We can't print money. And if there isn't congressional relief coming in a big way and quickly, it's gonna be an absolute bloodbath. And we're gonna lose every investment that we've made. So it's got to happen.
Thank you very much, Matt. Bev, thank you for giving us our final words as we get ready to turn it back to the coalition for the final remarks. Thank you.
Mine are simply, don't forget that the COVID happened. Don't behave as if it won't happen again. Understand that we've got to build a healthcare system that is with that as part of its awareness, as that part of its planning. So that's one of the things. The second one is I'm buying Elena's earlier comment about leadership and mentoring, but I also want to be invited to the tables. And I'm not talking about me, but I'm talking about all those coming behind me and with me. There should be seats at the table in terms of making decisions about healthcare. And that will change the whole picture. If they look like me, or even better, they act like me, and let them have a seat at the table of decision-making around healthcare systems.
Well, thank you very much for sitting at this table for a very impressive conversation and for your brilliant perspective and insights today. We have a blueprint, if you will, for the reimagining, re-engineering, rethinking of the healthcare system, and we have such wonderful and diverse perspectives in all of you. So Dr. Jane, Dr. Parekh, Dr. Rios, Matt, and Bev Malone, thank you very much for joining us today.
Thank you. Thank you, Licy, and all of our panelists for your insightful conversation. We've really been honored to have you with us today, and we've really seen some great threads from this morning into this afternoon. So I'm now going to share my screen so that people can see our information and our partners that have been with us today. In addition, I'd like to now introduce Sean Martin briefly to close us out. Sean Martin is the Executive Vice President and CEO of the American Academy of Family Physicians. He also currently serves as the interim CEO for the National Coalition on Healthcare. And I'd like to thank Sean for joining us today and give us some final remarks to close us out.
Great, Michael, thank you so much. Well, first, let me start by just thanking Licy and Noam for moderating 2 exceptional panels. I thought that was just an incredible program. I want to thank all of our panelists that participated today to share their thoughts and wisdom. Want to congratulate the NCHC for an incredible program. John Rother, you, Michael, thank you for all the work to put this on. Just another great program brought to you by the National Coalition on Healthcare. So I pondered how I was going to close out this exceptional 2-panel presentation today on kind of reimagining our healthcare system amid crisis. But I'm going to do it by plagiarizing, if that's okay with everybody. And I'm just going to plagiarize a quote that Bev just made about 5 minutes ago when she says, "We were having a conversation we never had the courage to have before. And I thought that was just really powerful. And I think that is a great way to close out this conversation that we had today, is to just remain courageous about having this conversation that we're already having and continuing to work together to improve our healthcare system. So we thank you for joining us. Again, we thank our incredible panelists and our two great moderators. And Michael, I will turn it back to you.
Thank you, Sean. That concludes our webinar and our virtual conference for today. Thank you for joining us, and we'll be in touch soon. Thank you.